Welcome back to the deep dive. We're taking that deep breath and jumping right into some really interesting material you sent over. Today, it's all about the thyroid gland. Seems small, right? But wow, the anatomy around it is complex. We're really going beyond just its place in the neck. We want to map out those critical relationships, the high-stakes neighbors, basically, and pull out those clinical landmarks that, take you from just knowing the facts to really understanding the implications.
Exactly. And maybe the best place to start, the thing that really defines the thyroid anatomically, is its movement. It's quite unusual. See, the whole gland is wrapped up in this layer called the pretracheal fascia.
Okay.
And that fascia is actually attached, physically anchored up top to the cricoid cartilage.
Ah, okay, the cartilage in the voice box area.
Right. And the clinical takeaway. Because of that specific anchor point, the entire gland gets pulled up and down every single time you swallow.
So it's constantly shifting position then.
It absolutely is, which, already tells you something about surgery in this area. It's not static.
A moving target right from the start. Okay, so where exactly is this moving target situated? The sources put it right at the front of the lower neck, just below the larynx, the voice box. And it wraps around the trachea, the windpipe, kind of on the front and sides.
Anterolaterally is the term.
Right. And shape-wise, everyone thinks of that classic butterfly, yeah.
That's the one. Two lobes, like wings, connected by a thinner central part, the isthmus.
And those lobes are sort of pyramid-shaped, pointing up with the base down low, roughly C5 to T1 vertebrae level.
Yeah, that's the general neighborhood, C5 to T1. But let's focus on that isthmus for a second.
Okay.
That little bridge of tissue, it sits just underneath the cricoid cartilage. And critically, it lies directly over the second and third tracheal rings.
Okay.
Yeah.
Why is that so critical?
Well, think about a tracheostomy. You're making an opening right there in the trachea. The sources really stress this. If that isthmus is right there, or maybe larger than usual, it's a direct hazard. You have to be incredibly careful. Major bleeding risk right at the airway entry point.
Wow, okay. That makes total sense. The central connector is literally draped over the spot you might need access to. And didn't the sources also mention a variation, something about an extra lobe?
Oh, yeah, the pyramidal lobe. Good point. About 40% of people have it. It's usually a small projection heading upwards from the isthmus. Just another anatomical variant you've got to be aware of.
So many potential little differences. Okay, we know it moves. We know its basic shape and location. What about its immediate neighbors? You mentioned the fascia.
Right, the pretracheal fascia encloses it, but the structures next to it are key. This is where that high-stakes proximity really comes in. Some of our notes actually had a nice little shorthand for it, the 3-3 tubes rule.
The 3-3 tubes rule. Okay, what's that?
It helps you visualize the immediate surroundings. Medially towards the midline, you've got the trachea and the esophagus running right alongside the thyroid. 2 tubes.
Airway and food pipe. Got it.
And then laterally on the outside, you have the carotid sheath. That contains the carotid artery, jugular vein, vagus nerve, basically the main highway for blood and nerve signals to the brain. That's your third tube system.
So 3 major conduits, airway, digestion, neurovascular bundle, all crammed together right next to this gland.
Exactly. The 3-3 rule just locks that geography in your mind.
Yeah.
Any issue with the thyroid immediately puts those major systems at risk.
That's a really helpful way to think about it.
Oh.
Okay, let's zoom out just a bit to the more superficial structures.
Yeah.
The sternocleidomastoid muscle, the SCM. Big diagonal muscle in the neck. Why is that such a key landmark here?
The SCM is crucial because it's like the main boundary marker of the neck. It sits within the investing fascia, this outer layer, and anatomically, it's what divides the neck into the anterior triangle at the front part and the posterior triangle behind it.
That it defines the surgical fields, essentially.
Pretty much. And interestingly, the SCM and the big muscle at the back, the trapezius, they actually share the same nerve supply.
Oh, really? Which one?
The accessory nerve, cranial nerve 11, controls both.
Huh. And the SCM's main job is turning the head right.
Yeah, primarily ipsilateral rotation, turning your head to the opposite side. But bilaterally, they help flex the neck forward. But for our purposes, its main role is as that big, visible landmark. Find the SCM, and you know where the major zones of the neck begin and end. You really need it for orientation before you go deeper.
Okay, that makes sense. So we've set the scene, defined the borders now. Let's dive into what you called the surgical highway. This feels like where things get really, really critical.
They do. Because now we're talking about the blood supply and, crucially, the nerves that travel right alongside those blood vessels. This is our anatomy isn't just interesting, it's potentially life-altering.
Right. So the main artery supplying the thyroid.
Primarily 2 big ones. the superior thyroid artery, the STA, coming down from above, and the inferior thyroid artery, the ITA, coming up from below.
Okay, STA and ITA, where do they originate?
The STA is actually the very first branch that comes off the external carotid artery, high up in the neck. It supplies the top part, the superior pole of the gland.
First branch, okay. And the ITA?
The ITA has a deeper origin. It branches off the thyroid cervical trunk, which itself comes from the first part of the subclavian artery, down near the collarbone.
Got it. Coming up from the chest area.
Exactly.
Well, wasn't there mention of a sort of wild card artery too, something rarer?
Ah, yes, the thyroidea artery. Good catch. It's pretty uncommon, maybe in 3% of people. But if it's there, it's a big deal surgically. It usually comes directly off the aortic arch or the brachiocephalic trunk and runs straight up the front of the trachea to the isthmus.
Directly from the aorta. Wow.
Yeah. So if you're doing surgery, especially something like a tracheostomy or thyroidectomy, and you encounter unexpected bleeding right on the trachea, you have to consider the thyroidea. It needs careful control.
Okay, so STA, ITA, and the occasional thyroidea. But you said the real danger lies with the nerves nearby.
Absolutely. The arteries are vital, of course, but clinically, their biggest significance is often as landmarks or maybe tripwires for two extremely important and very vulnerable nerves.
Tripwires. Okay, that paints a picture. Let's start at the top then, with the superior thyroid artery, the STA.
Right. The STA is your guide, your landmark for finding the superior laryngeal nerve, the SLN. Specifically, it's the external branch of the SLN that runs very close to, sometimes even loops around, the STA near the top of the thyroid lobe.
And what does that external branch of the SLN do?
It supplies just one muscle, the cricothyroid muscle.
The cricothyroid. Okay, what's its job?
Its job is to tense the vocal cords. Think of it like tuning a guitar string tighter. When the cricothyroid contracts, it stretches the vocal cords, raising the pitch of your voice.
So it's for hitting the high notes.
Precisely. So if that external laryngeal nerve gets damaged during surgery, maybe while tying off the STA,
What happened?
the patient might not lose their voice completely, but they often lose the ability to produce high-pitched sounds. They might notice their voice gets tired easily, or they can't project as well, or sing high notes.
That's what the sources called voice fatigue, wasn't it?
Exactly. It sounds subtle, maybe, but for someone who relies on their voice, a singer, a teacher, even us doing this, it can be devastating. And the difference between avoiding injury and causing it is literally millimeters when dealing with that artery and nerve bearer.
Incredible precision required. Okay, so the STA is linked to the risk for the high notes via the SLN. What about the other major artery, the inferior thyroid artery, the ITA?
Okay, so now we move to the ITA, and this is paired with arguably the most critical nerve in this whole discussion, the recurrent laryngeal nerve, or RLN.
Recurrent laryngeal nerve. Okay.
The relationship here is incredibly important and also variable. The ITA crosses the path of the RLN. Sometimes the nerve runs in front, sometimes behind, sometimes between the branches of the artery. And the sources were absolutely emphatic about this. You must identify and protect the RLN before you ligate, before you tie off the branches of the inferior thyroid artery.
Find the nerve first, then deal with the artery, not the other way around.
Absolutely critical. Because if you just blindly clamp or tie where the artery is, you have a very high risk of damaging that nerve.
And the consequences of damaging the RLN, what are they? They sound serious.
They are extremely serious. Remember how the SLN's external branch only did the cricothyroid for high pitch?
Yeah.
Well, the RLN supplies all the other intrinsic muscles of the larynx, all the muscles responsible for opening, closing, tensing, relaxing the vocal cords for speech and breathing. Everything except that one high-pitch muscle.
Wow, okay. So injury's bad.
Very bad. If you damage the RLN on just one side, a unilateral injury, the typical result is hoarseness of the voice, because one vocal cord isn't moving properly. You might also get some dyspnoea, some shortness of breath, especially when exerting yourself.
Hoarseness and breathing difficulty.
Yeah.
Okay. What if both sides are injured?
Bilateral RLN injury. That's a surgical emergency. If both nerves are damaged, the vocal cords can end up paralyzed close together. This can cause stridor, a high-pitched, noisy breathing sound due to airway obstruction and potentially aphonia, the complete loss of voice. It can even compromise the airway significantly.
That is terrifying. Stridor and aphonia. The stakes couldn't be higher.
Not really. It highlights why meticulous dissection and nerve identification are paramount in thyroid surgery. That relationship between the ITA and RLN is one of the most crucial anatomical points in the entire neck.
Okay, so this contrast, the subtle high-pitched loss from SLN injury near the STA versus the potentially catastrophic voice loss and breathing issues from RLN injury near the ITA, that really drives home the importance of knowing these specific artery-nerve pairs.
It absolutely does.
Right. Now, quickly, how does the blood get out? Venous drainage?
It's a bit simpler. You've basically got three main veins: superior, middle, and inferior thyroid veins.
Okay, where do they go?
The superior and middle thyroid veins generally drain upwards and laterally, emptying into the internal jugular vein.
Makes sense. And the inferior?
The inferior thyroid veins head downwards, usually in front of the trachea, and they typically drain into the left brachiocephalic vein, lower down in the neck or upper chest.
Got it. Any surgical points about the veins?
Yes, one specific detail often mentioned: the middle thyroid vein. It's usually described as being quite short and direct, and because of that, it's often the first vessel surgeons intentionally ligate and divide during a thyroidectomy. It's kind of an early key step in mobilizing the gland.
Shortest vessel, first to be tied off. Good clinical pearl.
Okay.
Moving away from blood vessels?
Yeah.
What about lymphatics, the drainage system for, well, fluid and immune cells?
The lymphatic drainage from the thyroid is really extensive. It doesn't just go to one place.
Where does it head?
It flows into several groups of nearby lymph nodes: the pretracheal nodes right in front of the trachea, the paratracheal nodes alongside it, and the prelaryngeal nodes in front of the larynx.
Okay, multiple local stops first.
Right. And from those initial nodes, the lymph then drains further out into the main deep cervical lymph node chains, both upper and lower, along the jugular vein.
So quite a wide network.
Very wide. And this leads directly to a really important clinical rule, something the sources stressed.
Which is?
Because that drainage is so extensive and involves all those neck nodes, any proper examination of the thyroid gland itself is considered incomplete if you don't also carefully examine the cervical lymph nodes.
You have to check the whole drainage basin, essentially.
You absolutely do. You're looking for any signs of spread or related pathology in those nodes. It's mandatory.
Makes sense. Okay, let's shift gears one last time to a specific condition mentioned. Thyroglossal duct cysts. This is more of a developmental thing, right?
Yeah, it's something that arises from how the thyroid gland forms embryonically.
And the sources highlighted something pretty surprising about treating them specifically: the recurrence rates after simple surgery.
Yes, it's quite striking. If a surgeon just does a simple excision, just cuts out the cyst itself, the chances of it coming back are incredibly high. The numbers were like 45% to 55%.
Wow, almost a coin flip whether it comes back or not after simple removal. That seems really ineffective.
It is. And that high failure rate is precisely why a more complex but much more effective procedure was developed and is now the standard. It's called the cyst trunk operation.
Cyst trunk operation. Okay,
Yeah.
What makes it different? Why does it work so much better?
It works because it addresses the root cause, the embryology. The thyroid gland doesn't start in the neck. It actually begins way up at the base of the tongue during fetal development.
Oh, right, and it migrates down.
Exactly. It travels down the neck to its final position, leaving behind a temporary channel or tract called the thyroglossal duct. Normally, this duct disappears, but sometimes remnants persist.
And that's where the cyst forms.
That's where the cyst forms, along that persistent tract. And crucially, that tract often passes through or is intimately attached to the hyoid bone.
The little U-shaped bone in the neck.
That's the one. So the cyst trunk operation doesn't just remove the cyst, it removes the entire presumed path of that embryonic duct. This means taking out the cyst, the tract itself, the central portion of the hyoid bone, and even a small core of tissue up towards the base of the tongue where the tract originated.
You have to remove part of the hyoid bone itself.
You have to. If you leave that central part of the hyoid behind, you're leaving behind the pathway where the duct remnant likely runs, and the cyst is almost guaranteed to recur. The cyst trunk procedure understands that embryological journey.
That's fascinating. To fix the problem, you have to literally retrace its developmental steps and remove the whole path.
Precisely. It's a beautiful example of anatomy and embryology directly informing surgical strategy for much better outcomes.
So let's try and wrap this up. We've covered a lot of ground: the moving target nature of the gland, that useful 3-3 tubes rule for the neighborhood, and then the really intense surgical highway where millimeters separate safe passage from nerve injury, especially around the sternocleidomastoid and iteral pairs.
Yeah, those artery-nerve relationships are probably the highest yield takeaway.
It all seems to come back to this idea of high-stakes proximity, doesn't it?
It really does.
Yeah.
The thyroid might be small, but the structures packed around it carry immense clinical weight. Operating there demands respect for that anatomy. Knowing the specific landmarks, like using the STA to anticipate the risk to high pitch, or demanding RLN identification before touching the ITA, that's not just trivia, it's fundamental to safe practice.
Absolutely. Okay, so here's a final thought for you, our listener, to mull over. We talked about how superior laryngeal nerve injury can cause that subtle loss of high pitch or voice fatigue, maybe not life-threatening, but career-ending for a singer or public speaker. Given that, how does the almost microscopic precision needed to avoid that specific nerve while dealing with the superior thyroid artery really underscore the profound importance of knowing every single anatomical detail, every potential variation in this critical area of the neck? Something to think about. Thanks for joining us on this deep dive.